All right, hello everyone, and welcome to the first live event organized as part of the McGill World Restart Our Heart campaign. It's a global initiative that aims to increase public awareness and rates of bystander CPR. This campaign is student-led and faculty-supported within the Faculty of Medicine and Health Sciences at McGill University. And our 2023 campaign seeks to further disseminate bystander resuscitation knowledge and skills across the community in Canada and abroad. My name is Naomi Malka, and I'm a fourth-year medical student at McGill University and the Ambassador Relations Lead of World Restart Our Heart, McGill. So we have the privilege of being joined by leaders in in-hospital cardiac arrest survival. Our guests today have made incredible efforts in improving cardiac resuscitation and survival outcomes. And through their clinical experience and scientific research, we will learn about in-hospital care of cardiac arrest survivors, and then also contrast the American and Canadian approach for caring for these patients. So first, I'd like to introduce Dr. Doshi, an esteemed associate professor of emergency medicine at the University of Pittsburgh School of Medicine. And he currently leads as the clinical director of the University of Pittsburgh School of Medicine's post-cardiac arrest service. And with 2 decades of experience dedicated to emergency medicine and cardiac arrest, he founded the post-arrest reanimation service at Allenby General Hospital in 2007. And since 2019, Dr. Doshi has overseen the clinical direction of the post-cardiac arrest service across UPMC's hospital network. In addition to his clinical work, he has authored over 30 significant publications in cardiac arrest care and is a globally recognized speaker on the subject. And an outstanding educator, Dr. Doshi has implemented innovative educational modules and is an honored member of the UPSOM Academy of Master Educators. And we are also joined by Dr. Wong, and Dr. Wong is a dedicated internist and critical care physician at St. Michael's Hospital, and she serves as an associate professor in the Department of Medicine at the University of Toronto. Passionate about education, she effectively uses simulation to train cardiac arrest teams. Holding esteemed positions, Dr. Wong is the director of the Cardiac Resuscitation Education Program and the Deputy Physician-in-Chief for the Department of Medicine at St. Michael's Hospital. She pioneers multidisciplinary team training through a novel simulation program, collaborating with various departments to ensure comprehensive in-hospital cardiac arrest training. This program, coupled with the practical application of mock arrests and a unique cardiac arrest database, underlines her commitment to optimizing cardiac arrest responses and improving patient outcomes. So to start off this panel, I'd first like to share a special video created by members of our student and steering committees during the 2020 campaign on how to respond to cardiac arrests. So in the next 60 seconds, I invite you to learn how to save a life.
In Canada alone, every 12 minutes, someone suffers from a cardiac arrest. If you don't do anything, they are going to die. In the next 60 seconds, we're going to teach you how to save a life.
If you see someone lying unconscious, the first thing you want to do is check if they're responsive. If they are not responsive and not breathing or breathing abnormally, they are likely suffering from a cardiac arrest.
Call 911, let them know that someone suffered from a cardiac arrest, send someone to find an AD if there's one nearby, and then start chest compressions.
For chest compressions, find the center of the chest, put your dominant hand down, interlock your fingers, and push hard and push fast.
Using an AED is really easy. You just apply the pads, turn on the machine, and follow the voice instruction. The machine will analyze the rhythm and tell you if a shock is recommended.
So Dr. Wong, thank you for joining us tonight. The chain of survival in cardiac arrest begins with swift emergency response activation, followed by resuscitation. And you're uniquely positioned by your research in optimizing CPR readiness, CPR training, and emergency cardiovascular care science as well as by your role as a clinician teacher for training cardiac arrest teams. Could you share insights into the crucial initial steps and aspects of in-hospital cardiac arrest care and their significance in influencing long-term survival?
Sure, I'm happy to answer that question, actually, and thank you for having me. So when I started my career, I focused a lot of my attention on the cardiac arrest team and making sure that my cardiac arrest team did the best job possible. And in building my database, one of the things that we always asked our teams was whether or not CPR was in progress or the defibrillator and pads were attached upon arrival of the arrest team. And we noticed that, in fact, very rarely was that, in fact, the case. And interestingly, we actually had to take a step back, not saying that I didn't want to keep training my cardiac arrest team, but in fact, it was the first responders that we had neglected to actually train. Interestingly, when we actually surveyed our first responders, many of them actually were not up to date with their BLS, were not familiar with the equipment within our institutions, did not even know how to work with themselves as a team, didn't even understand their role in cardiac arrest management, much as the bystander doesn't understand their role to try to help somebody be sort of resuscitated, right? They keep thinking EMS is going to arrive, they will save the patient. Same thing in the hospital. They think the arrest team is arriving. I'm actually going to hurt the patient. I'll just wait till they arrive. They'll take over. And crucial minutes are being lost by doing this. In addition, we actually had to train our teams to actually recognize that a patient was arresting. In ICU and in the emergency department, we're really good at determining when a patient's actually deteriorating, not doing well, potentially arresting. Interestingly, that's not the case on the floors. And it was very eye-opening to realize that, in fact, the most critical aspect of our cardiac arrest management was the first responders. All the people on the floor, medical students, occupational therapists, physiotherapists, the nurses, the CAs, all these people that we don't even focus our attention on initially. And so we've actually created a program, which we call the First Five, which focuses on the arrest team, identifying the arrested patient, calling for help, initiating CPR, bringing in the defibrillator and attaching the pads, such that when the team arrives, they actually can do what they need to do.
Wow, thank you, Dr. Wong, for highlighting the important factors that contribute to the emergency response to cardiac arrest. In that vein, proper advanced resuscitation is recognized as a pivotal step in the chain of survival. And so from your perspective as the director of the Cardiac Resuscitation Educational Program at the University of Toronto, how could you discuss the various methodologies and strategies you found most effective in training both students and multidisciplinary teams? And how do these methods work to optimizing in-hospital cardiac arrest responses and enhancing patient outcomes?
So I have the luxury of having access to an amazing simulation team, and my multidisciplinary team is also very much engaged with what we are doing. And so as a result, we've been able to create both in-lab simulation training to help the team sort of recognize each other's roles. One of the things that we really try to capitalize on is that it's a team approach rather than a leader trying to tell everybody else what to do. And I empower every member of the team to be able to intervene or to say something if they feel that an important piece of information is being missed. So in the lab itself, we actually bring an entire multidisciplinary team together, including physicians, the nurses, the respiratory therapists, anesthesia, so that they can train together in that environment to understand how each other works in that sort of environment. We then incorporate those same philosophies and bring in mock arrests within the hospital, because hospital arrests are much more complex than you would think. The issue not being, do I have the right people there? The issue being, I have too many people there, and how can I actually access the right resources in a timely fashion? The other area that we also encounter is outpatient arrests that occur within hospital. So we have our lobbies, and we have individuals that will enter our hospitals and sometimes use IV drugs and actually have an overdose within our public areas. And our teams are not usually equipped, unlike the emergency department or even EMS, they actually don't know how to deal with those situations. So we've created mock simulations to try to help them understand how to actually optimize their performance. And we involve security, our front door lobby people to help with crowd control and bringing PPE to the scene. So by actually bringing the actual simulation to the environment itself, you uncover issues with actually running arrests, but you also help people understand what it is that is available to them and how they can optimize their situation and the importance of the team. So this obviously occurs at St. Mike's, but as a result of the stuff that we were doing at St. Mike's, the rest of the institutions all across the University of Toronto have started to incorporate this. And again, it's surprising to me that a second-year resident in internal medicine is expected to take on the role of a leader in the midst of all this chaos. And so I think it's cruel and unusual punishment to subject them without any kind of training. And that's sort of why we do a lot of what we do. We also take our first responders, those people that I told you about, the BLS, we also bring them in and incorporate them so that they can also have practice or training with the team because they're part of the team.
Thank you, Dr. Wong. I guess it's really encouraging to hear about the positive outcomes that come from all of these training methods, and it goes to show the importance of continuous education and also including everybody who's involved in the hospital setting. So Dr. Doshi, thank you for joining us tonight. It's widely recognized that recovery is one of the most under-researched links in the chain of survival. And you direct the post-cardiac arrest service at the UPMC. Could you describe what this service includes by way of specific assessments and multidisciplinary consultations? And also, could you explain how this comprehensive approach impacts patient outcomes?
Absolutely. Thank you for having me. It's an honor to be here. I apologize, I'm on service because the person who is supposed to cover for me is still in Philadelphia. So I dress like this and my phone is here in case it goes off. So I apologize in advance. Thank you for that introduction. We are really blessed here that we have a number of folks interested in resuscitation throughout the spectrum. And what you've alluded to really nicely is that there is the chain of survival, and the chain has multiple links. And resuscitation is the beginning of the link. And how do you build your resuscitation program so you actually are successful there really matters on your milieu, as we've just heard. And after that, someone needs to take up the ball to do the rest of it. And one of the things I would kind of charge those of you on the webinar to think about is to kind of change the paradigm of how we think of cardiac arrest. And Dr. Wong brought this up a little bit already, but it's not the end stage of a disease, it's an event itself. Now, multiple things cause that event, but after the event, the results are very predictable, actually, and they're kind of definable, and they're probably modifiable. And so what do I mean by that? So after a patient is resuscitated and comes to us at UPMC, either an in-hospital event or an out-of-hospital event, the majority of our patients are actually out of hospital. I think most big institutions have very robust response teams. And so many people are prevented from having a cardiac arrest in the hospital by kind of aggressive assessments. But then they come to us and we kind of try to say, what can we do to modify things like brain injury, be structured with neuroprognostication, do true neuroresuscitation that's tailored to the patient. But as you alluded to, all of that, none of that actually matters unless you do the last link in the chain of survival, which is recovery. And I use the word survivorship more than I'll use recovery. It's kind of how I think about it, but it's a similar concept. We call our patients all survivors and we call their families co-survivors. And they go through a predictable, definable set of sequelae after they're resuscitated. And after they leave the ICU, a lot of us who do resuscitation work started either in the EMS or emergency medicine or ICU spaces. And a lot of us are now realizing we have to become internists and we have to become family physicians. And we have to look at this space because our colleagues don't know that much about it. And so what I'll start with is that survival is still low. And we know that we're increasing, but survival is still low. Use the number 10% from an out-of-hospital arrest just for a ballpark figure, and it's not accurate depending on where you are, but it kind of helps the idea. That means that very few primary physicians or GPs are going to have more than one patient who survived a cardiac arrest in their practice. If you were a GP and you were asked to know how to manage hypertension and only had one patient in order to use that for your milieu, you wouldn't understand it. You wouldn't understand the nuance of medications, of sequelae, et cetera. So what we've learned to do, and I'm an emergency physician, I kind of chose not to be a primary physician. My wife does that, and I'm not interested. But what I found is that we know what these sequelae will be. We've seen hundreds to thousands of patients, and now we can kind of say, we know where you're going to be in your recovery, and we can kind of find it. Not that everyone's recovery is direct or linear or the same, but at least we can find milestones. So to your question, what do we do in our service? We provide integrative neuroresuscitative and neuroprognostic care that we bring either to the bedside or by tele. Our system is actually quite large. In the Western Pennsylvania part of UPMC, we have 18 hospitals. We only serve one directly, and we try to do televisits at other ones, and we're still working how that works out. That's challenging. And then what we do is we meet the patients after they've been resuscitated from the ICU and look for the predictable, definable, and modifiable sequela, which we break down into 5 big categories. And there's a very nice survivorship statement from the American Heart Association I recommend everyone read, which my partner was the primary author on, Kelly Sawyer. And I use a little bit of a different kind of model than she does, but I kind of find 5 big domains people need. They need physical or functional assessments. Patients in the ICU or receive CPR may have sequela from that. They have cognitive cognitive concerns. I think most people think of that when they think of cardiac arrest, that people could have brain injury. That one's kind of one everyone thinks of, but you need to assess it, monitor it, and then treat it. A large number of patients have mental health or psychiatric concerns. I like the term emotional just to be a little less negative on the concept, but we know at least a third of patients have true mental health diagnoses that become as a result of their cardiac arrest, not pre-existing. We see patients with what we call spiritual concerns. Many people have this epiphany of life and their life is very different. And how does that fit with their spirituality or their religion or their worldview? And then we have a big social domain that we see people have to navigate. How do they get back to work? How do they get back to the things they enjoy? And so we've built this rubric, and we provide patients with a roadmap that we say, these are the expected things people see. You may see some or all of these, but they're not unusual. There are people you can talk to about this and figure it out. And we can talk about kind of who we refer people to in a bit, but I'll stop there for that.
Thank you. Thank you very much. That sort of patient-centered and multidisciplinary approach is truly commendable. Dr. Doshi, despite advances in care, patient outcomes after sudden cardiac arrest remain disheartening. There's only a 12% rate of unfavorable neurological recovery. And in response to this issue, I've seen that you've pioneered studies evaluating the long-term survival benefit of treatment at a specialty center after cardiac arrest. Could you discuss what factors are associated with long-term outcomes for sudden cardiac arrest patients who survive until hospital discharge? And also, how do individual interventions compare to entire system care interventions in their efficacy to improve these outcomes?
Yeah, another great question, thanks. And it's very similar to what Dr. Wong described, that it is the system of care and it is multidisciplinary. It takes a village to kind of take care of people with multiple issues. And if you've had a cardiac arrest, all your cells in your body were affected, right? So the fact that you have multi-system sequela makes perfect sense. So what we've built here is we use our post-cardiac arrest service kind of as the linchpin, where we will be a consultant service to whatever team is primarily taking care of the patient. Depending on the ICU, it's a different team. And we say, where is your expertise and where do we need more expertise? So patients who go to the heart ICU do really well. They don't need a lot of help from us to kind of say, what about their heart? But maybe they'll need more help with cognitive concerns. If they go to our neuro ICU sometimes, then sometimes we have to remind them a little bit more about the heart, because these are people who are specialists who live in their kind of milieu and are great at it, but don't always cross. So what we've built at UPMC is we get a multimodal, multidisciplinary group of people for each patient, starting with our post-arrest service, and then we assess. But every patient gets a neurointensivist, whether it's our service or the neurointensivist service, a cardiology assessment, which can be done kind of, depending on what they need. Often people need electrophysiology. Sometimes they'll need an interventional cardiologist. Almost everyone will need secondary prevention from a cardiology standpoint, even if it was an overdose of drugs, like something happened and their heart's still affected, we need to think about it. We look to see what the cause of their arrest is and really tailor secondary prevention to that. That could be secondary prevention for coronary vascular disease, or it could be secondary prevention for addiction medicine, or it could be something in between. And so we are lucky enough to have an addiction medicine specialty service here. Of course, we have a psychiatry service, so people who have intentionally tried to harm themselves causing an arrest. Patients with traumatic events, we need to figure out what that trauma was from. Why were they in a car crash? Was it used to alcohol use disorder? Was it used to something else that we need to work on? And we get those specialists involved. And then what we do is, as the patient improves, we look at these predictable, definable sequelae, and we get a comprehensive rehab specialist consult for every one of our patients. So the way we do it in our system at UPMC, physical therapist and an occupational therapist will see the patient first. That happens on every one of our patients, even if they're like wide awake and they were fine. If they were in the lobby of Dr. Wong's hospital and she resuscitates them really quickly and they wake up and they say, what do I need? We still get the physical therapist and occupational therapist involved, because what we've learned is that physicians actually aren't that good at assessing if people have needs. I would love to hear your thoughts in Canada, but I would tell you the hardest cognitive thing we ask our patients to do in the hospital is order from the menu. So they get a menu and they have to order a meal, and that's the hardest thing we actually ask them to process with their brain. So in that vein, we also get neurocognitive testing, multimodal neurocognitive testing on every patient. We use here locally the MoCA, which of course is a Canadian tool, and not necessarily validated in the setting of cardiac arrest, although we're working on that as we speak. And we actually do multiple tests. We've built some all local in-house testing as well. And we do 2 to 3 tests on every patient to see where they are. And really for us, it's kind of binary. Do they need services or do they not? And if they're not, then we're okay and we'll watch them as they go forward. But if they need services, we do get our physical medicine rehab colleagues to see them. Many of our patients do go to inpatient rehabilitation. Those who don't, almost all are referred to our outpatient traumatic brain injury clinic, which is the clinic we just happen to have locally that works on brain injury. And so we've just made associations with them, and they'll see our patients, do very similar testing and assessments, and decide do they need to continue. I said we will get our mental health consultants in if we need to. And then what we've started doing is we do standardized mental health scales in the hospital. So we do GADS, we do a HAD-7, different kind of things in the hospital, and we do resilience scales as kind of trying to see, does resilience really matter, and how they've approaching themselves and their spirituality. We have a really kind of strong association with our hospital chaplaincy. Many patients have spiritual questions, and depending on their pre-existing religious beliefs or spirituality, those may manifest differently. So we get someone to talk to. And then the last thing that we're most excited that we do actually is we offer every one of our survivors and co-survivors a peer support. So we've been doing cardiac arrest care here for 15 plus years, and we have many patients who've survived a cardiac arrest, many who are 10, 15 years out. And what we try to do is match people with somebody who's gone through their similar life change. As another example, everybody on this call knows somebody who's had cancer. We all know someone. If your neighbor had cancer right now and asked you, like, where can I go to meet someone with cancer? You could find them someone they could talk to. That's not the same for cardiac arrest. And it's partially due because the survival is so low. So most cardiac arrest survivors never really get to meet someone who's gone through the thing. So we try to bring a peer to every patient. That can be done by email, that can be done by phone, sometimes at the bedside. But we try to offer that to everyone. So that's kind of what we do. And we think that kind of wraparound level of services really hits all of these domains. And then we follow these patients. So there are no outpatient providers. So we call them at standardized kind of time periods. We call them at 1 week, 1 month, 3 months, 6 months, and 12 months. And just do a check-in, see how things are going, see what's kind of come up, and then refer them to the appropriate services in the system.
Wow. The amount of specialists and services you're able to involve is really impressive and important. I also love the idea of the peer support group. Even I've been working with closely with survivors here in Montreal, and we created a survivorship group, and I can already see the impact has been so meaningful for them. So I'm glad to see that that's carrying on in the States as well. And so Dr. Wong, cardiac arrest patients, they frequently require ICU care post-arrest. And as you mentioned in one of your papers, there's a concerning trend towards increased patient adverse events, even in academic institutions. And so drawing from your research and experience on the issue, could you discuss what strategies and initiatives effectively reduce these errors in critical care settings?
So first of all, I just want to say I want to work with Dr. Doshi. I mean, that is an amazing program that you have. I have some like clinical envy, I'm not going to lie. So when we're done,
Can I just interrupt and say that we have a lot of envy of Canada most of the time. So
that is
only
outstanding. Oh my God. Like hands down here, like that's amazing. So back to critical care. So again, although, you know, management, once you get to critical care, is somewhat standardized. The things that I actually would say is that we actually struggle to identify the patients that are at risk for cardiac arrest. So we have ICU outreach teams. That's something that has been adopted across the board, across the world, but nobody's ever been able to prove that this actually works. In addition, we have these tools that can try to tell you or predict when a patient's going to go down, and you're trying to prevent the cardiac arrest, and yet somehow none of those tools have ever truly worked to truly predict when those patients are going to deteriorate and have a cardiac arrest. Because the idea would be if you could prevent the cardiac arrest, that would be the best thing, right? Because then you wouldn't have to deal with the post-cardiac arrest care, right? So when we talk about adverse events, I think a cardiac arrest is the adverse event. If we could prevent that, that would be amazing. But we're still struggling with how to identify those patients prior to having a cardiac arrest. And you think that within the hospital, we should be able to identify that? Surprisingly difficult. We don't have monitors on all of our patients, so we can't figure out the minute that they have the cardiac arrest. So many of our arrests actually are unwitnessed in the hospital, other than in the emerger in the ICU, right? So that's the first adverse event. So we need to figure that part out. The second part is that a lot of people don't do neuroprognostication well. So a lot of people will say, look, at this patient isn't doing well at 24 hours, even 48 hours, and say, you know, their chance of good neurologic outcomes exceedingly low, and then approach a family and start talking about withdrawal of care. And that's actually too early to do that. Particularly, we had targeted temperature management, and we were all excited about that. And we thought, okay, that's going to help us, you know, improve the survival for our patients. That bought us maybe 7 days, because we used to make patients super cold. We would sedate the crap out of them, and then unfortunately it would take them forever to wake up. So at the very least, you had a longer period of time. But now, interestingly, we don't target temperatures of 32 to 36 anymore. We're really targeting 37. We just don't want them to have fevers anymore, which is, by the way, actually exceedingly difficult. People think they can do that, but they are probably having a really hard time achieving that. So in fact, preventing hyperthermia is actually really important, and a lot of people probably struggle with that. In addition, because we're not sedating them anymore, they're potentially withdrawing care too early. So I think that if I had to actually say where we're causing the biggest harm, it's in those two categories: before they actually have the arrest, and post, in that window where we aren't giving them enough time to actually see if they could survive this period, right? And particularly young patients, they have so much potential to recover, and I think we are calling it quits too soon. And in Canada, I would argue that, unlike in the US, where we have the multi-modal approach and we have lots of consultants coming in and trying to help our patients, in Canada, it's a little bit more difficult to get my consultant to come in and actually do my assessment. So for example, if a patient had a cardiac arrest where you had to shock, if it's unclear what their neuroprognosis is, they will not do the test to see if the patient needs revascularization, because what's the point of doing that unless the brain is intact? And so that gets delayed. And so we further contribute to morbidity and mortality in our patients because they are at risk for other events occurring. And again, the rest of the care that occurs in our patients, you know, the ARDS, the acute kidney injury, the liver failure, the infections, those are pretty standard in many of our patients that arrive in the ICU, and we're pretty good at managing those, but I would argue that those other points are where we actually struggle.
Thank you, Dr. Wong. And Dr. Doshi, the post-cardiac arrest service at UPMC developed a comprehensive post-cardiac arrest discharge toolkit. Could you delve into the inspiration behind this toolkit's creation? And could you walk us through the process and key considerations that went into its development? And finally, what kind of feedback have you received from people who have used the toolkit, and how has it influenced its ongoing evolution?
Yeah, great question. So the reason we moved into the survivorship space is because we got really angry that we did a lot of neurocritical care on somebody and then nobody actually did anything with them after they made it to the floor. And then they went home without services and they didn't know what to expect. And patients came back to the hospital and they came back worse. Actually, there's been a number of studies now that patients, if you look at kind of standard neurocognitive testing, is worse when they get home than in the hospital. Part of that's an artifact because we don't test it well in the hospital. Part of that is because it's just a lot harder at home. And so if you ask people to like, hey, how you doing in the hospital? Yeah, pretty good, ready to go home. But you ask them to go home and make a turkey sandwich and to put together all the steps of that, that's much harder. So what we came to the realization here, kind of just organically, it wasn't like one thing, is that if we didn't continue to comprehensively look at patients throughout the continuum, then all the work we did in the ICU to not withdraw care and to do temperature management to whatever we want and to fix their acute liver injury, none of that actually matters long term if you don't get people back to what they want to be, right? If you send someone home who was playing tennis and they never play tennis again, isn't that really a bad outcome, even if they're alive and they're with their family, if they want to play tennis again, right? Like we need to kind of keep that in effect. So what we did is we said, organically, we were talking to people about this, but none of this was ever written down. And anyone who's done in-hospital work with patients knows that a lot of what we tell people is lost because they're getting many inputs, right? The cardiologist is talking to them about their defibrillator and the rehab specialist talking about this. And mostly they just really want to go home. And like, they really just want to stop seeing doctors. They've been in the hospital for a long time. Their ribs still hurt. They want to take a shower. They don't remember everything we talk about. So we said, we just need to write some of this stuff down. So we worked with actually a very grateful family who had a very long haul with their cardiac arrest to get better. And they helped us develop, and we iterated with a couple of our other survivors, just kind of what was life like, and we wrote it down. And we broke it into different spaces, and we've added things as time has gone on because many patients get new devices into their body after a cardiac arrest, whether it's a stent or a defibrillator, but there's no place for them to keep all that data together. So we just put a page on there where you could stick those little cards on, and now you can keep the page with you as opposed to having to keep 5 cards for your stents and for your defibrillator. We wrote a place where we can write down the resources in their neighborhood, and we'll get to a little bit of the difference between the American and Canadian systems here soon, but we're very fragmented, right? It depends on what your insurance is and where do you live and where's the rehab and all those kind of problems. So if we know that, then we'll write it down. You're going to be following up here, here, and here, make these follow-up appointments because you have to do some of the work yourself, but at least we can give you, you don't have to find the 15 pieces of paper to do it. And to your question, does it help? That's a harder question. We haven't randomized people to receiving this and not receiving this. We didn't think that was right to do. We have a lot of anecdotal data that when we started doing this in a comprehensive way, and part of what we actually do is we have a part-time case manager who works for us. And so she deploys a lot of this. We don't use clinician time. We showed that our readmissions went down 30%. So as a marker of people feeling better and not needing to access healthcare again, we think that's a good marker. And anecdotally, we hear from patients who actually we never even took care of at times, who then I give this to. Just, I gave it to you, Naomi, and we give it to people who like never were involved with us before. And we talk to them and they say, oh my God, this is exactly what I'm feeling. This is so much better. I now understand the sequela. So we get a lot of good anecdotes back. But we really think this comprehensive approach up front is what matters, just like the comprehensive approach in the neuro ICU or the cardiac ICU is what matters, is to have someone looking at that patient holistically. Just as Dr. Wong said, we have to continue that same concept throughout.
Oh, thank you for sharing. It's really amazing that you also collaborated with survivors and their families to create this toolkit. And the post cardiac arrest service primarily attends to in hospital care once they're leaving. When patients transition from the ICU and then eventually discharged from the hospital, what continuity of care is ensured? And what are the short-term and long-term services or resources to which these patients are typically referred to from these two critical transition points?
It's a great question. We're an academic medical center. So when the patient leaves the ICU, they lose all their doctors and they get a whole new set of doctors who've never met the patient, never met the family, don't understand the journey that the family may have gone through over weeks in the ICU. So we provide that continuity. And that's something we found was very important, was that our service really makes sure that we stay with that family through the journey. They go to a whole new set of doctors who we can work with, but the only people they see that are constant are us. And we thought that was a very important thing. Just like you would want to see your own primary practitioner when you go to the doctor. When you see their partner, it's like less fun and less meaningful, right? They don't know everything about you that your GP knows. And we try to do that. When they leave the hospital, we do not have an outpatient clinic. So we would love to see these patients from an outpatient standpoint, but no one will pay to do that. So right now we don't have an outpatient clinic. We're actually trying to build a use case for one, and we hope to do it. And what we have done, a very odd thing, where we've got grant funding from multiple sources, including research studies and grateful patients, and we pay a team of student workers to do this work. So they meet the patient along with our case manager in the hospital, and they say, hey, I'm Joe, or whatever you want to call that person today, because they change a lot. I work with the post-cardiac arrest service and Dr. Doshi. He wanted me to talk to you about this. And they talk for a little bit. They give them the toolkit and they say, I'm going to call you in a week. Is this the right number? What's a good time? And they set that meeting up. And then they call and they do the same kind of assessments over and over and over. And what they do is they grab one of our clinicians if there's a problem. We're pretty lucky. Again, we're really blessed here. We have a number of physicians who do this. We have about 5 people who do this at least part-time. And we have 3 full-time advanced practice providers, 2 nurse practitioners and a PA. And so they take the primary kind of brunt of our clinical work, and we'll call the patient and help the patient through their journey, but they can't bill that either. So one of the biggest barriers is, how do you do this unless you have another way of funding it? And our APPs who are down this hall for me right now basically are just doing it because they're really invested in the mission. And that's probably not sustainable long term. So that's the next step that we're looking for, is how do we sustain that so that clinical work gets done, which is really important.
Mm-hmm. Thank you. And Dr. Wong, I'd like to discuss the Canadian healthcare system's approach to in-hospital cardiac arrest care. Could you talk about some of the stronger aspects of our system, and what differences do you see with Dr. Doshi's explanation of the American healthcare system? And finally, do you think any of these discrepancies present opportunities for improvement in the Canadian context?
I mean, I do not have a program that can parallel what Dr. Doshi is doing with his program. We don't follow our cardiac arrest patients, which is a real problem. I would agree. It's like any of the ICU patients that leave, they also deserve long-term care because all of them have cognitive issues and functional issues and mental health issues that follow any sort of admission to ICU. And I think that that's a deficiency of both systems, to be honest with you, because I don't know that anybody does that in any sort of degree. And I agree that the people that follow them, their family doctors, even the internist, or when they go to rehab, don't truly have a true appreciation of the impact that kind of trauma has had to any individual. So I think that that's a deficiency in both systems, but for sure, I do not have a system that has already been, which sounds amazing. If I could have that system, I would 100% adopt that system. I think the biggest issue, though, rather than comparing Canadian and American, I would actually argue that it's urban and rural. And I think that both US and Canadian systems suffer from this. If you are in an urban center and you have high volumes, you're going to get likely fantastic care, right? For the most part. Whereas survival from cardiac arrest goes way down in rural areas. One, because they don't have the resources, the time to getting care is so much longer. And in addition, socioeconomically, perhaps this is a bigger issue in the US and in Canada. The difference in the quality of the care is probably also pretty significant, right? Whereas in Canada, if I had somebody who had no fixed address, who has no resources, has no source of income, I could still consider putting them on ECLS, or otherwise known as ECMO, if I needed to. I think that that would be a bigger stretch in the US. I don't know that that kind of resource would be available to someone. The one thing that I will say that the US has that Canada does not have is a better cardiac arrest registry. So they have Get With the Guidelines, and some Canadian institutions have adopted it, but not enough. And as a consequence, we're not able to truly get enough in-hospital cardiac arrest data to help inform decision-making, inform how we actually manage our patients, even like from time to admission to time in the ICU to post-admission. If we could gather more of that data, I think it would help us better inform where we need to focus our strategies in terms of helping all of these patients. And in the US, it's part of their standard of care and quality metrics that they actually have to sort of deliver that information, whereas in Canada, it has not yet become one of our quality metrics. And so as a consequence, it's sort of, if somebody has an invested interest in making sure that somebody is doing good quality care, then maybe that institution will do well, but that is not always true in all institutions. And again, I would argue that Canadian institutions are not as well populated in terms of nurses, in terms of specialists, and as a consequence, you're not always going to get that kind of care that you might see in an institution that has better resources, but of course you have to be able to afford those resources. So perhaps that is, again, the big difference between Canadian and American healthcare.
Thank you, Dr. Wong. I think it's interesting that, there's quite a discrepancy even between different Canadian hospitals. And I hope that's an area that we could aim to improve. And Dr. Doshi worked in the American healthcare system for over 2 decades. Could you discuss the strengths and weaknesses of the American system? And, do you think that the American system can learn anything from the Canadian system?
I think many of us who work in the United States would much rather work in Canada, but maybe the grass is always greener. Without getting fired, so hopefully my administrators are not on this call, money drives the US healthcare system, and that is unfortunate if you want to do things that are not well recouped, and unfortunate if you don't have the means to access healthcare. We don't actually have the problem. I mean, we don't really ever have to worry about assessing a patient's ability to pay to provide them the resources. That's not normally a problem, but when they're no longer emergent, it is. So how do I get the person who's unhoused or uninsured into a comprehensive rehab plan without an insurance mechanism to pay for it? No one can afford that, right? I think that's where we tend to struggle with a lot is it really matters who and how the person is once they're out of their acute illness. And our system's pretty good about it. UPMC is a very big system, so it has a pretty good financial pull. And so we don't really get tasked to say, oh, this person's been in the hospital for a week and they don't have insurance. What are you going to do about it? They tend not to worry about it too much. But really getting them the resources later becomes really, really a big problem. The other thing I would love to put a plug in for is what Dr. Wong said about data collection being the most important thing. You can't hope to improve a system unless you actually know what the outcomes you have are. And if you can't tie those outcomes at least loosely to some type of metric, how did you know what worked and what didn't? And how can you actually have someone improve? And back to the question about money in healthcare, for people suffering a stroke in the United States, those metrics are reportable and can change reimbursement for healthcare systems and hospitals. That doesn't happen in cardiac arrest in the United States. So while we collect the data and we use that for academic purposes, and I think we get way better and we learn how to take care of patients better, we don't always have the kind of the hammer to the healthcare system to say, look, this is really important. And if we ever got that, that would actually change cardiac arrest care a lot. Because then we would move it from what I would say an ad hoc basis that we do at times, depending on where you are, to really forcing a professional basis. And in the United States, in the last, in my career, there were no stroke services when I started as an emergency physician. You just kind of took care of a patient with a stroke, and like you just did some stuff, and you kind of did the right thing or the wrong thing, and then they either got better or they didn't. Now everyone in our institution is admitted to a stroke service. Everybody with a true stroke in our UPMC system gets a consult to our stroke service by tele from multiple hospitals, because we know the value of having that expertise. But that value is really only shown to the system if there's a monetary change. So that's something that I would love to change in the United States healthcare system, is let's collect this data and hold ourselves accountable. Absolutely, right? We shouldn't just do it because I say it. We should do it because we're making people better, and prove we're making people better, and then make changes. So I think that's something we can really improve upon. And we have the same rural kind of urban difficulties here. I can see the hospital over here from my window. There's a lot of doctors there right now. At night, there's intensivists in the house all the time with multiple people staffing multiple ICUs and multiple ER docs there. That doesn't happen in most hospitals in the United States. Uh-oh, did I freeze? Okay. So that is really a divide we need to really work on here. How do we provide resources to people? And I actually really like the telemedicine approach. Obviously, I can't do everything. It's hard to do a really detailed neurologic exam myself via camera. But if I can train the nurses at a hospital to do that neuro exam and provide it to me, and I could see the patient, then I think we can bring a lot of the same resources to people. It's not always high-tech resources that matter. It's often a really thoughtful assessment and a holistic approach to a patient that I think we can do. So I think there's probably room in both of our systems to do that.
Thank you, Dr. Doshi. And thank you, Dr. Wong, you both brought up, the importance of data collection and, I think the effect that it has on improving care, from the very, very beginning. And so we've reached the end of this exciting live event. And I would like to express my appreciation to Dr. Wong and Dr. Doshi for your illuminating perspectives on in-hospital cardiac arrest care, and most importantly, for your time. I want to take this opportunity to invite everyone to join the World Restart a Heart 2023 campaign in its mission in disseminating bystander resuscitation knowledge and skills. Thank you, everyone.
Thank you.
Thank you.